Ouzounian is a cardiovascular surgeon at University of Toronto, and she will be speaking on surgery of the distal aorta.
Thanks very much, Philippe, and the committee members. Thank you, Ismail, very much for the invitation. I also would like to declare myself as an aortic nerd, and spending the day talking about aortas is really, can't think of anything better to do. Do you mind putting my slides on the main screen, please? They're up here. I see them here, but we don't see them there. There we go. Okay, perfect. So unlike the proximal aorta, where although certainly size is not the be-all and end-all, size still is a good predictor of outcome, and we have excellent elective surgery for the proximal aorta where we can preserve the valve with very low risk. You'll hear in the next 20 minutes or so that surgery on the distal aorta is a much more muddied and unclear situation. So we'll talk about the distal aortic disease, particularly focusing on the aortic arch and thoracoabdominal aorta. And everybody knows this quote from one of the fathers of aortic surgery, Stanley Crawford from Houston: no patient should be considered cured of the disease. And I think this is true for every patient with genetically triggered aortopathy, as well as every patient with dissection. So who develops distal aortic disease? So who do we see this pathology in? So we really see it primarily in two groups of patients. So in my practice, these are the patients who have distal aortic problems. So scenario one is patients who have a previous type A dissection. They successfully had proximal aortic repair, and then their arch and distal aorta dilates. The other common scenario is a patient who has a de novo type B dissection. And these, unfortunately, are unpredictable, and they often occur in patients with normal diameter aortas. Furthermore, elective repair of the descending and thoracoabdominal aorta is not a low-risk undertaking, and so we don't have good indications of when to do elective repair in those patients. Distal aneurysms in patients with genetically triggered aortopathy is really rare and without preceding dissection, in my experience. Certainly we see atherosclerotic, degenerative thoracoabdominal aneurysms, but these are not the patients with hereditary aortopathy. So we usually see them with dissection. So, and just to remind you of the classification, we go with type A and type B as our cornerstones for treatment, but patients who have type 2 dissections are privileged in a sense because after their proximal aortic repair, this can be a potentially more curative procedure, and there are at less risk for distal aortic events. So you heard very elegant, you saw the elegant video by Ismail of elective aortic root repair. As we move to the arch and thoracoabdominal aorta, surgery becomes more complex and certainly has increasing risk. So what does surgery entail? So we'll talk about a few different scenarios. So if you have arch and thoracoabdominal aortic disease, and in patients with genetic aortic disease, we often see multi-segment disease where their arch and their thoracoabdominal aorta is dilated. Classically, what one would have is a arch replacement with an elephant trunk. Now, with patients with genetic disease, we tend to stay away from this configuration of a island replacement of the arch vessels because we know you can develop aneurysms in that island. And so we typically use this approach with multi-branch grafts to the arch vessels. This still carries, even in the best hands, a 5 to 10% risk of stroke and death. So these are much higher risk procedures than elective root replacement procedures. But as surgery has evolved, we use antegrade cerebral perfusion, we use more moderate hypothermia techniques. Surgical techniques have evolved, and this has become a much lower risk proposition, but still higher risk than root replacement. In patients with multi-segment disease, you then have an option for either open or endovascular completion, and we'll hear more about the role of endovascular procedures in the next talk. apart from the conventional elephant trunk with just a soft graft sitting in the descending thoracic aorta, in recent years we've had advances in hybrid grafts. So these are grafts that are dacron in the first segment and then a stented segment distally that sits in the descending thoracic aorta. And unlike just a TVAR where it's just stent floating in native aorta, this has a very durable proximal landing zone. So the arch has been replaced. It's all dacron proximally. So I do think that there is a role for these devices. This is the Thoraflex graft. This is the Evita graft in patients with genetically triggered aortic disease. And in some patients where the distal dissection is limited to the descending thoracic aorta, this can also be a curative procedure where the entire diseased aorta is treated. And this is what it looks like. This is the proximal aorta has been replaced. The distal aorta has been replaced. This patient had a large aneurysm in this segment. The rest of the aorta may not ever dilate. So unlike a soft elephant trunk where you do have to go back for a second procedure, this may save you from doing a second procedure. This is another type of, this is a very novel device that is not available in the US yet, but has been, we've participated, and so has the Montreal Heart Institute, in the first worldwide clinical trials with this device. It's a novel type A dissection stent, and it's an uncovered stent with bare stent frame across the stent. This is can be placed really anywhere across the arch in zone 0, 1, 2, or 3. It's meant to be used in the setting of an acute type A dissection, and it has low radial force. So although right now it's contraindicated in patients with Marfan or other connective tissue disorders, we may see a role for something like this in the future. And I'll just show you a case that I saw recently. There's a 55-year-old gentleman, otherwise healthy. He had acute onset chest pain, but then his leg started tingling and then became painful, and his leg problem actually brought him to the emergency room. Vascular surgery saw him, and they fortunately asked for a CT scan. His left leg was ischemic, but he was otherwise very hemodynamically stable. He had a CT scan, and you can see on the CT he had malperfusion of his left carotid and also malperfusion of his left common femoral artery with a type 1 DeBakey dissection with a large root aneurysm with a tear in the usual spot in the proximal ascending aorta. So this is what his echo looks like. We took him to the operating room. And as you know, patients who have type A dissection, the reason the mortality remains so high with type A dissection is in most cases it's due to us not being able to fix the malperfusion. And the risk of death triples with every organ system that's malperfused in type A dissection. So this is what his root looks like in the operating room. And so we did a valve-sparing root, proximally replaced his ascending aorta, and then deployed this uncovered stent across the entire arch. And so this is his echo at the end of the case. And we also use echo to look at our frozen elephant trunks to see that they're expanded. And what we want is the true lumen to be more expanded. And if you only replace the ascending aorta and do nothing distally, what you will almost always see is a tiny, tiny compressed true lumen distally with a pressurized false lumen, which is a predictor of growth and poor outcome in the long term. And this is his post-op scan. Both his carotid and his leg malperfusion resolved. And this is part of the benefit of a device like the AMDS stent. In the clinical trial in the DARTS registry, we had 95% resolution of malperfusion radiographically with the use of this device, which is quite impressive. It remains to be seen how it will be used in our patient population. So moving distally, open thoracoabdominal aortic repair. This is complex surgery. It's really should be done in, we know that the outcomes of this procedure are very volume dependent. It should be done in centers of excellence. So I trained in Houston, where Coselli's done, he really has the world's largest experience, and Safi across the street also has huge experience with thoracoabdominal repair. The extent of the aorta we replace is directly related to the risk of paraplegia, death, and other complications. So extent 2, which is often what our genetically triggered patients require is the highest risk procedure, because we're replacing the entire aorta with all of the segmental blood flow to the spinal cord, and the risk of malperfusion to kidneys, bowel, legs, etc. And similar to the arch, when we do thoracoabdominal aortic repair in patients with Marfan and other connective tissue disorders, we don't do patches for the visceral segments, but we use this configuration, which is a Coselli branch graft with separate branches, because we don't want that visceral patch to dilate over time. And these are just some pictures of patients who had this operation. So surgical approach to the distal aorta really has to be tailored to the patient. So I'm going to just show a few examples of patients in the two scenarios we talked about. The first one was previous type A dissection and then came with distal aortic pathology, and the second scenario was de novo type B dissection. And just to give you a flavor of the variety of presentations that we see with these patients. So this is actually, this was my very first patient. I didn't even know where the locker rooms were and where the scrubs were when I showed up, and this is a 26-year-old who had a mechanical Bentall years before, had a cardiologist, had repeat echoes of his valve, but never had distal aortic imaging. And he came with an 11-centimeter thoracoabdominal aneurysm with pain and contained rupture. And, we took him to the operating room. He had a vocal nerve palsy, but he otherwise did well and went home. He had an emergency operation. This is another patient, very similar story. So there's a 42-year-old patient with Marfan. 20 years ago, he had a mechanical Bentall for type A dissection in another province. And he had regular follow-up with serial echocardiograms, looking at the valve, looking at the root, but he never had cross-sectional imaging of his aorta. His family doctor found popliteal aneurysms and sent him to my vascular surgery partner, and my vascular surgery partner said, oh, you had a type A dissection and you have Marfan, let's scan your aorta. And this is what he had, a 7-centimeter arch and an 8-centimeter thoracoabdominal aneurysm. And so because his arch is dilated, as you can see, we can't just repair his thoracoabdominal aneurysm, even though it's, by numbers, it's bigger. So this patient needs a complex staged operation. So he had a reduced sternotomy, total arch with a conventional elephant trunk, because we knew we had to do an open operation afterwards, and then an extent 2 thoracoabdominal aneurysm afterwards. This is another patient with an MYH11 mutation, 13 years after type A dissection. I actually met her because I operated on her daughter for an acute type A dissection, and she had, she was a tiny woman, and she had extensive disease, severe AI with a large root, a dilated arch, and a large thoracoabdominal aneurysm. She also required a staged procedure with a root replacement, total arch, and we had to, replace her carotid all the way up her neck, and then an extent 1 thoraco. This patient had Loeys-Dietz with a TGFBR2 mutation. He had a type A dissection that was successfully repaired in another city, and then just the proximal descending thoracic aorta blew up over time. And actually, Tim, this was your patient. You called me, you said, Maral, you need surgery right away. And he had almost a 6-centimeter, but it was really focal. Only the proximal descending thoracic aorta was dilated. And so we did a left thoracotomy and just replaced the first segment of the descending thoracic aorta. You'll see here he has an anomalous vertebral artery origin off his arch, which is also associated with aortopathy. So that's in the first scenario. So patients who have type A dissection, they really are at risk for future arch and thoracoabdominal dilatation, and their entire aorta needs to be monitored. Now, what about the patient with genetic disease with a de novo type B dissection? So this is a patient of mine from the past few months. She's a 53-year-old woman with a TGFBR2 mutation, no syndromic features, and she was actually identified after her son sadly died of an acute type A dissection. He made it to the operating room in a different province and then died on the table. She's, devastated, depressed, and really wasn't keen to have really any intervention. She got screened. She had the same variant, and her aortic root had been followed for some time, and it had been stable for 4 to 5 years. And her distal aorta was really not very remarkable. It did have this little a little bit of ectasia there, and she does have a little bit of tortuosity. Shane, you have to calculate her VTI for me. But she was being treated medically. She was on appropriate, she was on beta blockers and losartan, and then she presented this past year with an acute type B dissection, initially managed medically, no malperfusion, no acute complications, no reason to intervene acutely, but her proximal descending thoracic aorta grew very quickly from 3.8 to 5.3 in 6 months, despite very, very good blood pressure control. So she has a chronic expanding type B dissection. There's really no other option for her than open surgery in this patient with known Loeys-Dietz and TGFBR2 mutation. So she had an extent 2 thoracoabdominal repair, and she was dilated all the way down to her bifurcation. We did it with left heart bypass, spinal drain, and a Coselli branch graft. She did well with she did quite well after surgery, and she's still being followed. And now I'm wondering, after Shane's talk, when do I operate on her root, since she has a 5-fold risk for type A dissection after she's had type B dissection. So we're imaging her. If she budges at all, I think I'd operate on her. I was thinking 4.5 before, but now I'm thinking if she dilates at all anymore, I'd offer her valve-sparing root. This is another young patient with Loeys-Dietz syndrome, also a TGFBR2 mutation. He had a valve-sparing root repair at Sick Kids at age 13 for a very focal type A dissection limited to the proximal aorta. He has syndromic features. He had skeletal features. He had some lung, mild emphysematous changes in his lung. His family history was significant for his father, who died with a type A dissection at the age of 28. His sister has the same variant. Her aorta is normal. We're following her, but only skeletal manifestations. So he was actually in our clinic being followed regularly on medical therapy. He presented to outside hospital with an acute type B dissection, again treated medically and sent home. So when these patients present, and you'll hear more about type B dissections later, so if there's no impending reason, urgent reason, they do much better with medical therapy than with intervention, certainly with open intervention. So he was treated medically, and this is his what his aorta looked like in February. And what happened, so he was due to see me 6 weeks after his type B dissection for another scan. We scanned him a couple times in the hospital, and then he was in a small center in Northern Ontario, and then he was to come to Toronto 6 weeks later for a repeat scan. His mother drove him to the city and found me in clinic and said he's having ongoing chest pain. Even though his blood pressure had been very well controlled, he had this grumbling chest pain. So I saw him in clinic. We sent him to the CT scanner, and in 1 month his aorta had gone from 3.2 to 6 centimeters. So he wasn't going to go home. So he got admitted to the hospital, and we operated on him. You can see how large his tear is, and so that's likely partly why his false lumen grew so quickly. But he had urgent open extent 1 repair, and his dissection stops at his visceral vessel, so we also stopped the repair there. Post-operatively, he actually he was extubated initially, doing well, and then had 3 days later a respiratory arrest secondary to mucus plug. I almost had a cardiac arrest as well when they called me, but fortunately he got bronched, and mucus plug was suctioned out, and he recovered well otherwise. He still has his own native aorta and his abdominal aorta, so he's going to be followed indefinitely. I'm going to skip this next patient because it's quite similar, but similar idea, where normal MRI and then an acute type B dissection. Even patients who are followed regularly can have, unfortunately, despite good medical management, acute type B dissections, and they're unpredictable. Tim alluded to this paper of that Tim and Dr. David reported on the outcomes in Toronto of patients with Marfan syndrome and valve-sparing root replacement. They die from distal aortic disease. So this is a key message for all of our patients. We need ongoing, lifelong follow-up of the entire aorta. This is an interesting paper looking at trying to find, of 600 patients with Marfan, trying to find some predictors of type B dissection. And in this paper, prior root repair and a descending diameter of more than 27, which really isn't very enlarged, each of them had a risk factor hazard ratio of over 2. And when you combined both factors, you had really a much higher risk of type B dissection over time. So I think you've heard my message that patients with, any patient with aortic dissection or genetic aortopathy needs lifelong imaging of their entire aorta. There's really multiple approaches to the arch and thoracoabdominal aorta surgically, and the surgical approaches and the indications for surgery have to be personalized. So to summarize, the lifelong risk of distal aortic disease requires lifelong surveillance, especially in chronic dissections. We really need a tailored approach, and surgery may need to be done in multiple stages. Often people with distal dissections need proximal elephant trunk done first before their distal aorta is repaired. And our goal is to prevent late aortic deaths, and unfortunately type B dissections in particular are really not predictable. We need there's an urgent need for better tools to predict and manage distal aortic disease. So I will end with that. I wanted to thank GADA and the LDS Foundation for their support of this meeting. We really are indebted to you for everything you do for our patients and our community. I'm hoping you will join our meeting next year, run by Dr. Horn in Halifax in September. Thanks very much.
Questions? Yes, microphone.
Maral.
Jessica, yeah.
Okay, so you mentioned it a little bit. So sometimes like those patients are transferred from an outside hospital and come directly in the OR. They are in their 30s or 40s, and now we have access to all those devices, so the one from Osiris or the Turaflex. So do you take time to think about it? Because for me, I'm having all those things and I'm putting it, and after you do your genetic testing and everything, and it's a Marfan or they have connective tissue and you did a frozen elephant trunk. So do you think about that before for an emergent case like that? About what you're going to do between a frozen or elephant trunk? Or?
Yeah, no, that's a great question. I think it's often these patients come and they're undiagnosed, so it's their first presentation. We didn't know they had a genetically triggered disease. Certainly if they're younger than 50, we're thinking this is something likely hereditary. And my first approach is what's their clinical presentation? Do they have malperfusion? And where is the tear? And so often on the CT scan, you can see where the tear is, not always, but often. And so if I see that the tear is past the left subclavian and it's a retrograde type A dissection, then I'm thinking we're going to do a Thoraflex, okay? Or if the arch itself is dilated. If they have malperfusion distally, if they have any kind of malperfusion, I'm almost certainly going to do some type of frozen elephant trunk distally. If it's an older patient in their 70s, and it's there's no malperfusion, we're not going to increase the risk of it. Your main goal is to get the patient alive home with a type A dissection. So I don't think the extended arch techniques are necessary in every patient. And if it's a Marfan patient who's a known patient with genetic disorder, but their dissection, they have no malperfusion and their tear is in the ascending aorta, for me, it's more important for me to do a valve-sparing route if it's possible and just limit it to the proximal aorta and then follow the distal aorta. If their tear is in the arch or the arch is dilated, then I would be more aggressive. But if their tear is in the usual location and they have no malperfusion, then I would do a valve-sparing route if it's feasible and leave the distal aorta alone. Reid.
Maral, thank you very much for your insights. We have great difficulty getting insurance coverage in the States for scans that are not viewed to be essential. So if you had a Marfan patient who had had a successful ascending repair, no dissection, you're going to follow that patient by chest CT, and you'll see the proximal descending aorta. you won't see the aorta much below the diaphragm. How important is it, do you think, number one, to follow the distal abdominal aorta in someone who has a normal proximal descending aorta, number one. And number two, since these patients are living much longer, thankfully, what do you think the interaction will be between Marfan aortopathy and the aortopathy that all of us are susceptible to in the abdominal aorta?
Great question. I think that's a tough one to answer, to be honest. Our patients in our clinic who have Loeys-Dietz, for example, we scan their entire aorta, even if it's not dilated at all. Every 2 or 3 years, we argue for an MRI from the brain to the pelvis. In Marfan patients, because the risk of visceral aneurysms and intracranial aneurysms is we think lower, although the data is not very strong, to be honest. I think we should do that study and scan them and report that. If their proximal descending thoracic aorta is not enlarged or dissected, I think the chances of you finding something in their abdominal aorta is fairly low. You could also scan them with abdominal ultrasound at the same time as you do an echo, for example, if just to limit the need for cross-sectional imaging. But I think it depends on the proximity, if they've had a dissection or not, and how the aorta progressed initially. If they've had elective root repair with no distal aortic disease, I would be less concerned about scanning their abdominal aorta in the long term.
Very much, Maral.